Hi, everyone, and welcome to the Trial Site News Podcast. I'm Erin, your host, and our guest today is Dr. Pamela Davis, and we are going to chat about interesting research that she and her team did on COVID-19 and its link to newly diagnosed cases of Alzheimer's disease. But first, Dr. Davis, thank you so much for joining us. We really appreciate you being here. And I was wondering, before we dive into this research, could you tell us a little bit about yourself and the work that you do?
Well, thank you for having me. I appreciate the opportunity to talk about our work, which is really the product of a pretty nice team that we've assembled lately. I actually am an internist who worked on cystic fibrosis for most of my career, until I became the dean of the School of Medicine at Case Western Reserve and spent 14 years in administration. And during that time, new drugs were developed for cystic fibrosis. And during that time, because of the demands of the administrative position, I had to close my lab. So when I stepped down as dean, I was very impressed with the opportunities that were afforded by informatics and artificial intelligence. And I began to collaborate with a brilliant group headed by Dr. Rong Zhu, a professor here at Case Western Reserve, on the use of informatics. And about that time, the COVID epidemic hit, and we decided we would look at the impact, at the reciprocal impact of COVID on chronic diseases and of chronic diseases on COVID. So that's how we got into this. We now have graduate students and postdoctoral fellows and medical students working with us, as well as some crackerjack technical staff.
Awesome, very nice. So you basically answered my next question, but maybe we can dive into it in a little more detail. I read through your study titled Association of COVID-19 with New Onset Alzheimer's Disease, published in September of 2022 in the Journal of Alzheimer's Disease. And I'll share that link for our listeners in the podcast description. But what made you want to explore this particular research question?
Well, Erin, there have been a number of suggestions that would make us worry about the impact of COVID on the brain. In many papers and prior investigations, it's been suggested that viral infections can promote Alzheimer's disease, viral infections of various kinds. And here we are with a virus that's dashing around the globe. And what does that mean for it? And a virus that we know affects the brain. I mean, it affects the olfactory nerves. You can't smell, you can't taste. It hides out in the olfactory nerves and the olfactory bulb. People develop encephalitis and brain issues in the acute phase. So we know that this is a virus that affects the brain. In addition, there are a lot of hypotheses that surround Alzheimer's disease that say that part of it is driven by an inflammatory response. And as we know from COVID, if you get a severe case of COVID, the inflammation is dramatic. We all heard about the cytokine storms that occurred early in the course of the disease. Those cytokines can cross the blood-brain barrier. So here we have, on the one hand, the hypotheses about viral infections in Alzheimer's, and on the other hand, the question of what is the impact of this potentially massive inflammatory response to the virus on the brain. And we thought we ought to look at what was happening. Honestly, when we got our results, we hadn't expected to see such an increase so soon. But that's what the data showed.
Okay.
And
let's get into the study then. Now, this was a retrospective cohort study.
Yes.
And over 6 million adults who were 65 and older who had a medical encounter between February of 2020 and May of 2021. So this was a lot of people.
Yes, it was.
A lot of people. And there was no previous diagnoses of Alzheimer's disease in this particular. Okay. So you had two cohorts basically amongst this big group, so to speak, those who were diagnosed with COVID-19 and those who were not diagnosed. Is that okay?
Yes.
Okay. And then you matched, you did propensity score matching, which
we tried to control for
right.
the variables that we know can predispose to Alzheimer's.
Right. And I just thank you for that. Just in case our viewers are not sure, because
what
there were
propensity scores.
Yeah, it's but yeah, it's good to know that you controlled for these confounders. So after you did that, what did you see between these two groups?
Well, we saw that the group who had contracted COVID had more new diagnoses of Alzheimer's disease than the group that had not contracted COVID. And the difference was bigger the older you were. So it was bigger in those over 85 years of age than it was in people from 65 to 74. And it was bigger in women than it was in men. But it was present no matter what age group you were in, no matter whether you were male or female, no matter whether you were white, black, or of Hispanic ethnic extraction. So it seemed to be a consistent finding, some areas worse than others. Now, of course, the risk in the population that didn't have COVID was not zero. So we're talking about an increase from maybe 5 per 1,000 to maybe 7 per 1,000 in the overall group, maybe a bigger increase, and that's an increase of about 70% on the hazard ratio. But the absolute risk is relatively small, but it's there and it's highly statistically significant. And this is a retrospective study,
right?
And we can provide evidence of association, but we cannot provide evidence of causation in a retrospective study like this. And of course, there are a number of things that are possible that could contribute to this. One of them is if you've been, if you're an older person and you haven't been to the doctor in a while, and then you get COVID and you present to the physician, maybe you had Alzheimer's disease before, but it wasn't observed until you actually, got to the physician. That's number one. Number two, we know that some patients have brain fog and other problems following COVID. And we think that the physicians who are making these diagnoses are mostly savvy enough not to want to make a permanent diagnosis like Alzheimer's disease unless they're quite sure and unless it has the hallmarks of Alzheimer's disease. But, it's always possible that there's something that is simply a short-term problem that's been entrained by COVID. Actually, we're hoping that's the case, because Alzheimer's disease is a terrible disease, and we don't want to see an increase in the incidence.
And just so our viewers know, in terms of how you diagnosed or Alzheimer's disease or what you used for that, you used a particular diagnostic code, is that?
We used physician diagnosis of Alzheimer's disease. We did not require that there be brain imaging or anything else. We did not require that the genotype be determined. We did not require that cognitive testing be included in the medical record. It was a physician diagnosis only.
But a lot of data. You had a lot of, over 6 million. That's a lot.
It's a lot of people.
Yeah. And I just want to go back to hazard ratios. Some people may not know what that is, but that's a particular it's a proportion
Mhm.
of something happening in one group versus another, correct?
Yes.
Okay.
Yes. So the hazard ratio overall for our patient group was, I think, 1.68.
Yes.
And so there was 1.68 times the hazard of being diagnosed if you had COVID compared to the group that did not have COVID. And I want to emphasize that the group that did not have COVID was not zero.
Right.
There
Okay.
were patients diagnosed in that group. There were just more patients diagnosed in the group that had had COVID.
And this was a year.
This is in the year following the
Yeah.
diagnosis. And
Yeah.
I should say that because we wanted to wait a year to see what happened over that period of time, we really didn't include people who got the Delta variant, because we stopped, before the Delta variant became prevalent in order to give ourselves a year of follow-up. So we didn't have patients with the Delta variant, and we didn't have patients who got the Omicron variant. So it's possible that there might be different hazard ratios for those groups. So that's one of the reasons that we really do want to follow up. And we'd like to take the group that we've already looked at and see what happens in year 2. Is the hazard ratio still increased, or does it fall back to the same as the non-COVID group? We think those are very important questions.
Research questions, absolutely. And you mentioned earlier that this is a retrospective cohort study, so you're not establishing causation here. This is correlation. So from your findings, is the next step to do this study, to do this 2-year study? Is that what we are planning on doing or hoping?
Well, we're certainly going to keep looking for more years going out from the initial diagnosis. But we'd also like to look at patients who had their first COVID in the Delta variant phase. That was a nasty variant, and it gave you more severe disease. The Omicron doesn't seem to be quite as nasty as giving you severe disease, but it sure was more contagious. And there are a lot of people who got it then. The other thing that we were just on the early phase of vaccination for the patients that we studied. It took us an absolutely short record time, but it took us till the end of the year that we studied to really have the vaccines fully on board. And we did not have Paxlovid in the group that we studied, because we stopped in 2021, and the Paxlovid didn't really become available until 2022. It's possible that Paxlovid blunts this, and that would be wonderful. We'd like very much to be able to look at that.
And that's that's the antiviral that was
yes,
produced by Pfizer and approved by the FDA for.
Yes.
Okay.
Yes, indeed.
Okay.
So antivirals, and we learned a lot more about taking care of COVID throughout the course of the pandemic.
Yeah.
And we learned to give steroids when people were really sick, so that may blunt some of the inflammatory response if that's something that contributes to this. So we, I think, have a baseline now to which we can compare a number of interventions. And we hope we can sort out what really, they all help the acute illness, but what really has an impact on the long-term problems that ensue.
Yeah, it's affecting so many people.
My goodness, yeah.
Can I ask you about the other study that you did on breakthrough infections? So just for our viewers, this was published in Alzheimer's and Dementia, the Journal of the Alzheimer's Association, that looked at breakthrough infections and hospitalizations among vaccinated patients with dementia in the US between December of 2020 and August of 2021. Is that right?
Yeah.
Okay.
So actually, the first study that we did was even before that. We looked at whether patients with dementia, including Alzheimer's disease, got COVID more frequently, before the vaccine.
Okay.
And we thought that was an important study. And honestly, we expected that it would all be accounted for by what we call comorbidities. So if you have high blood pressure, you're more likely to get Alzheimer's, but you're also more likely to get COVID. If you have heart disease, you're more likely to get Alzheimer's, but you're also more likely to get COVID, and so on, all those things. But when we controlled for all those things, there was still a twofold increase in acquisition of COVID infection in the patients with dementia, and particularly with Alzheimer's disease. I think vascular dementia was even higher at threefold. And we controlled for living in congregate environment. So if you were in a congregate living setting, in assisted living or something like that, we tried to control for that looking at the infection. So there are these patients with a twofold increase in the ability to get infected. So then we thought, gee, now that we're back, so that was actually part of the reason that the Alzheimer's patients moved up on the list for getting vaccines, because it was clear that they were at risk. And then we thought, well, we better look at and see if they're still at risk. And it turned out that they were. And whether it's because patients with dementia don't remember to distance and keep the mask on, and the vaccines are not 100% effective we think that the bigger the inoculum you get, the bigger the viral load you get. So if you're right in front of somebody with COVID when he sneezes, and you don't have a mask on, that's going to be worse than being across the room from someone. And we sort of thought that maybe patients with dementia don't remember to keep their masks on and don't remember to distance as much. But it's also possible that their vascular systems are compromised, their brain vasculature is compromised, and all those nice receptors that might be shielded otherwise now are available for the virus, and it makes us a little bit scared. So I think the reciprocal relationship between Alzheimer's disease and COVID is a positive feedback one in both directions.
That's interesting.
It worries us.
Yeah, no, of course. And I think this was an important population to look at. And as you mentioned in one of your papers, people with dementia weren't necessarily represented in the clinical trials. Right. And the average age was 52. I think you wrote 0.05%. So these are populations that you really need to look at closely and see what's happening.
Yes. Oh, yes.
And COVID, it seems to impact older people more so, and that's when.
Absolutely. Right.
So now, the overall risk in breakthrough infections for people with dementia versus people without, there was a difference there, or did that difference go away? Did the statistical significance go away when you also took into account for comorbidities?
It did not go away completely.
Okay. That was my question there. And then you did also look, what I thought was interesting, you looked at the rates between the fully vaccinated, which I believe you defined it as, getting 2 doses of a messenger RNA. Back then, yeah, it's there's up to date now, there's boosters and all that. But back then it was fully vaccinated versus, and then you had some people who were partially vaccinated, but you also looked at the difference in breakthrough infections in that group, right?
Basically, the more vaccine, the better.
Right. They didn't get as many breakthrough infections, which is interesting. I mean, because there's a lot of questions around durability. So I thought that was an interesting finding in your study. So are you planning on doing more research in this area? Are there studies that are ongoing or soon to be published, or in the preprint status?
We certainly, well, we don't have a preprint right now. We're certainly very interested in Alzheimer's disease. We have a grant from the National Institutes of Health to study the reciprocal interactions. And if we have some data otherwise that points the finger at elements of the inflammatory response, that maybe you don't need to control the COVID infection per se, but it might make a difference in dementia, in the subsequent dementia. So we're looking at that. And some of our studies actually utilize people who are taking these drugs for other reasons. And we look at, does that impact your ability, your risk for getting Alzheimer's? We did publish a paper before the COVID pandemic using the VA database, saying that if you had taken TNF alpha inhibitors for rheumatoid arthritis or inflammatory bowel disease, that you had a lower probability of developing Alzheimer's disease down the road. And that protective effect of the TNF alpha blockers lasted for years. So there was some very tantalizing data there. And we think it's worth thinking about. It's not, Alzheimer's disease is a terrible disease. It doesn't just affect the patient. It costs us a lot of money. In 2020, it cost us $300 billion for Alzheimer's disease. And not only that, but about 70% of the patients with Alzheimer's disease are taken care of by a family caregiver.
Yeah.
So it impacts the lives of the spouse, the children, the cousins, the siblings, the person who has to take care of that person. There is a huge impact of this disease.
Yeah. Anything
we can do to reduce the impact of that disease. It was kind of leveling off before the COVID pandemic. And it had been going up for a while. And then we started to say, well, there was this great Sprint study that said the tighter the control of your blood pressure, the less your chance of developing mental difficulties and heart disease and dying. So yeah, we should really control your blood pressure. So that was helping. And people were paying attention to the exercise issue. Even a little bit of exercise keeps your brain going. Yeah,
just get it in when you can. Just
and
move a little.
And now COVID comes along and whammo, we tell you, oh, no, you can exercise, but don't go near anybody else, It
was, that was hard for a lot of people,
yes, it was terrible.
Getting, staying inside, and it's depressing. You don't want to move. But I guess in terms, I'm always interested in modifiable risk factors. I think we should invest more in prevention as a country.
I do too.
But there, I know you mentioned high blood pressure. It kind of goes, I guess, in terms of, weight control, trying to maintain a healthy weight. I don't know about substances. You would know better than me in terms, alcohol, cigarettes, they probably never good for anything, but.
Well, they're not good for you, but probably if you have to choose what you do, moving and controlling your blood pressure are two the
biggest ones. What about sleep?
Oh, I'm an advocate for it. I love it. I think it's great.
Well, we have that in common. Okay. Well, this was all very interesting, and I really appreciate your time coming on the podcast to share your expertise with us. And you're doing great work. I hope one day we can find a cure for Alzheimer's disease.
Wouldn't that be wonderful?
Oh, it would be. It would be. I've seen it up front with some family members, and it's just heartbreaking, heart-wrenching, awful. So
it's terrible.
Yeah.
Well, thank you for having me, Erin.
Absolutely. And thank you to our viewers for joining in. And I will include links to Dr. Davis's research in the podcast description, and see you here next time.
Thank you.
Thank you. Thanks so much.